So under burns, this will have similarities to sepsis and ARDS because burns is a cause for acute lung injury. Now, imagine yourself getting burned, even if it's just let's say the lower part of your body. So let's say Hannah over Thanksgiving was frying her first turkey. Okay, so she dipped it, but then the wire slipped. Okay, dropping the turkey, and everything splashed. All the hot oil splashed over her legs. Okay, then it was boiling hot oil. So imagine how that will feel. And then what's happening to the tissues? And then the oil stuck to the tissues, right? And it's not easy to wash off. Okay, so is that a minor injury or a really major trauma? Okay, major. Okay. Now how the body reacts, we will describe. We'll see how the body reacts to how our cells, our blood vessels react to a burn injury. Previous graduates did come back and say they got questions on burn prevention, and the questions were on fire prevention. So there's a paragraph here on how to prevent burns. So it's in a chart 57-1. This contains basic information that we all should know already, but this will also include the location of fire extinguishers, for instance. Let's say how many, or fire alarm, smoke detectors. So how many do you have in your home? If you're in an apartment, the building, the city Department of Buildings mandate the number and location of the smoke detectors. Okay, so because they all inspect homes, right? Before they can rent it out, for instance, or before you get approval from the Department of Buildings, you have to comply with the fire code, correct? So they will check the number and location of your smoke detectors. So how many have you seen? So here, there should be one on every level of the home. So you have a basement, main level, and a second floor, for instance. There should be at least one smoke detector in every level. And then the batteries change at least once a year. So people have different. Have you ever changed them, the batteries?
Yes.
Only if they start beeping, right? But they should really be changed regularly, okay? Because by the time they beep, and then that's when you really need the smoke detector, right? Disaster comes when you least expect it. So they should really be changed regularly. So most people that I know change them during daylight saving time. So when we change clocks, they remember to change the batteries on the carbon monoxide and smoke alarms. Okay, and then just read the rest. Generally speaking, fires are preventable, correct? Meaning if we observe safety, so any fire hazard, every employer you've worked for, all of you have at some point worked for somebody, right? You underwent training, and part of the training is always fire safety, correct? And then we have drills. Even in school, we do fire drills. At your employment also, they will conduct fire drills, announced or unannounced. So the fire marshal would come and see if everybody is on their best game about fires, because fires can start like this, and we need to know what to do to stay alive. Now, of course, fires is only one type of burn injury. That's called thermal injury. So thermal burns can be moist heat, it could be dry heat, it could also be contact burns. So anything hot, you can sustain burns in 3 different ways. Okay, but there are also chemical burns. There are also radiation burns, and there's also um, uh, electrical injuries. Okay, so you can get electrocuted, that can also cause a burn. Then we have dry and wet chemicals, and then of course we have radiation burns as well. So it's not just fire, although let's say when you have electrocution, you can catch fire, correct? So if you get electrocuted, depending on the clothing and the circumstances of the electrical burn, it can spark a fire. So you can have both electrical and thermal burns at the same time. Now, the severity of a burn injury is determined by a number of factors. Number one is the age of the patient, because this will determine the skin's integrity, the ability of the skin to sustain or handle the injury. Let's say, of course, the more water content or the less water content of the body will determine the severity. So that means the very old, very young will have the higher mortality when they sustain burns. Next is the depth. How deep is the burn? How many tissue layers were involved? The amount of surface area. So this is what we will calculate. We will use the basic formula, which is the rule of nines, to calculate how much percentage of your body surface area was burned. The presence of inhalation injury, because most causes of death in fires really isn't getting burned, meaning the patient was already dead by the time they got charred. So cause of death really is smoke inhalation, right? Smoke or heat, you inhaled the fumes, or you just lost consciousness and died from the smoke. Okay, so that will kill you first before, at least, it's a painless death. You were dead already by the time you got charred. And then another is the presence of other injuries. So let's say you caught fire and then you trashed yourself around in the panic and then caused head or neck injuries, for instance, or sustained other injuries. Let's say you fell off a building or fell down the stairs. Another is the location of the injury. Where did you get burned? Obviously, if the burn affects these areas, the face, perineum, hands, or feet, that will determine mortality and your ability to rehabilitate. Because let's say the face, so what's located in the face? Our airway. Okay, so our airway that means facial burns are serious, or it doesn't have to be the face. Any neck or upper chest injuries also increases the risk of inhalation injury, because have you ever seen fire burn down? Have you seen fire burn down? It always burns upward. Okay, so therefore, so when you have any chest or upper arm burns, so that means the fumes will go up. So that means you will sustain inhalation injury. And what is our natural response to something scary? Do we exhale or inhale? We gasp, right? We go, have you ever seen someone got scared and they say, no, we always go, right? So therefore, we tend to inhale the fumes or the smoke. And of course, perineum, because these areas, are they nice areas to get burned at? No, plus they're not really the cleanest part of the human body, right? So they usually get infected because you make urine and doo-doo there. And then hands or feet. So these are the very body parts we need to take care of ourselves. So if we lose hands or feet or leg function, then we will be unable to take care of ourselves. Or if the patient has comorbid conditions, let's say heart failure, they have COPD, they have kidney problems, that will complicate recovery or survival. Any questions so far? Okay, so that determines severity. The next few paragraphs discusses the same things I already said. So age, very young, very old, and burn depth. So there will be a few questions here. You can Actually, I recommend reading the paragraphs as well, because although I can grab the questions on the table, however, the table is not very complete. The table has one, two, three, and four rows. You're lucky the author only has four. Other authors have six, because there is superficial, but then there's also partial thick, because the American Burn Association actually classifies the burn injuries not by degrees anymore, but by thickness. How thick is the burn injury? Meaning, let's say it's super partial, or this is also called superficial thickness. And then second degree is partial thickness. And then we got full thickness, and we have deep full thickness. For fourth degree or deep full thickness, this will now reach up to the muscle and bone. Okay, so these are similar to, if you're familiar with pressure ulcers, then this will be about the same. Okay. The examples of the burns are here, but the question on the test will be the appearance. What will the burn injury look like? I will not test you on the last column, which is how it heals, because we are not likely to work in a burn unit during the first year, okay? Because only specialized burn centers can take care of burn patients. However, if a burn injury patient is not anywhere near a burn center, a certified burn center, let's say you live in Queens, so the closest ones there that can handle burns are Elmhurst and New York Presbyterian. But if you're not close there, we'll have to take you to the closest hospital, correct? But every hospital is equipped to handle shock, can they? Can they start a central line? Can they give you IV fluids? Yes. So any hospital can render first aid, life-saving aid to you. But then once you're stable, they have to transfer you to a burn center, because they cannot handle wound care. Does that make sense? Okay, so any hospital can handle a unstable patient. So let's say you're taken to Flushing Hospital, okay, but a very small hospital, because that's where you sustain the injury, close there at least. So you'll be taken to the ER. The doctor can insert a central line, give you fluids. Once you're stable, you're not in danger of dying from shock anymore, then you will be transferred directly to either any, let's say, Bellevue, or any any burn center, certified burn center. Or if you're in Long Island, they have several there, Northwell Health, or even say Nassau Community Hospital. They have those are large burn centers. But I will have questions on the appearance. You need to recognize, what does a superficial thickness, a partial thickness, or a full thickness burn injury look like? Okay. Let's say I'll describe there's pain, or whether or not there are blisters. What do the blisters look like? Okay, what does the burn injury look like? Is it white? Is it red? Is it pink? Is it blanching? Is it not blanching? Okay. What will help is if you're familiar with your anatomy, so you don't have to memorize, because what really determines the color of the burn injury? Whether or not there is blood supply, correct? Okay, so therefore, where are the blood vessels located really let's say in our arm? What layer of tissue are the arteries and veins really located? Is it above or below the dermis? Below the dermis. So therefore, if the burn injury is now white, that means what happened to the blood vessels? They were burned off. Okay, so that if you look at it, so the more superficial the wound or the burn, the more colorful it is. Okay, so you'll notice here if it's superficial, it's still red because there's still blood flow. Okay, because the blood vessels are intact. Okay, but the deeper you go, look at the color now. Here, look at full thickness because now you burn through the blood vessels. So now the wound bed now looks dry, pale, okay, brown, and even leathery. Leathery meaning there's dead tissue. Okay, there's dead burnt tissue already underneath. And the blisters are only seen in the more superficial, more minor burns because you need the skin to be intact in order to have a blister. So no dermis means no blister. Okay, what's gonna hold the water? There's nothing. You burn through the whole dermis, then there are no blisters. Okay. Or I can use colors. So Canvas can handle JPEG pictures. So I can use a picture and then ask you, okay, what I'll use the pictures on your textbook to be fair. Yes, Shasha? Mhm. You see the bone?
Yeah.
No, that's already deep full thickness. That's 4th degree. You're familiar with porridge?
Yeah.
Yeah. So back home, we because in third world countries they make porridge a lot because it doesn't take a lot to make porridge. You just need half a cup of rice and then put it on a boil, throw in one chicken there for flavor. But the porridge is so hot, but then there's a layer on top wherein it prevents steam from escaping. So the child sees that, oh, it's probably not hot, right? So, and then they sustain burn. So there's a lot of that back home, and then they're injured as a child and then they grow up with the nasty scars. But at least they survived though. They didn't die. Okay, so I'll use pictures or just the description, okay, for the test question. Let's go now to the next factor. This is the TBSA. Okay, there are two formulas used. For us who are beginners, who are not working in a burn center, we will use the rule of nines. It's simple. The Lund-Browder method is really, really detailed. You look at the comparison here. No, we only have the rule of nines, but let me show you what the Lund-Browder method looks like, just for discussion purposes. Look at how many sections they divided the body. So this is the Lund-Browder methods. Okay, very detailed. So we'll stick with our nines. Rule of nines is very simple. Every body part is a 9. So here there are 9 body parts here. The whole head is 9. So 9 times 11, that's 99. To complete 100, we put 1% for the perineum. So that will include the penis, the testicles, or in the case of the female, it will include the labia as well. And of course, the rectum, okay? So the entire head is 9, but it's 4.5 for anterior, 4.5 posterior. Each arm is 9. 9 in one side, and then 4.5 on anterior arm, 4.5 for the posterior arm. The torso is quite big, so that's 2 9s, 2 9s in front, 2 9s in the back. Each leg are also quite long, so there are 2 9s each, 9 anterior, 9 posterior. So let's practice. Let's burn Bromwell. So let's say Bromwell is a 102-year-old female. So you can imagine 102, and she's what? You're 5? How tall are you? 5. Okay. And I need a weight because we need to calculate your fluids later, but we'll use your weight later. So right now she's 5 feet. And let's say Kurt was her nurse. So Kurt is her, it's Bromwell's time to have a bath. She's in a nursing home. So Kurt picks her up, puts her in a bathtub. Kurt got distracted. So there was a game, it was Super Bowl Sunday. And she put Brianna down on the bathtub, laying supine. And then he started pouring what he thought was a bubble bath. So he poured the bubble bath, but it turned out to be hydrochloric acid. I don't know who labeled the bottle. So it's a bubble bath bottle, but then someone filled it with hydrochloric acid. So he did this, okay? So now Rihanna is laying down from head to her heel in 2 inches of hydrochloric acid. So it's a chemical burn, right? And then because she's a 102-year-old, so what will her labia look like? It's going to be sagging already, right? So her labia is also sagging down and swimming in the hydrochloric acid. So calculate her TBSA. So she's laying supine, head to her heel. 2 inches of acid. Can't be 90. It's only the back half of Brianna. Too much.
You said it's only the back.
She's laying supine, head to her heel, covered in hydrochloric acid. 50.5. Who did not get 50.5? Okay, so back of the head is 4.5. Each back of the arm is 4.5 each. And then the whole backside is 18. Each leg is 9 and 9. And then 1% for her perineum. 50.5. All right. Okay, so that's one possible question on your exam.
4.5 times 3 and 9 times 2.
Are you gonna make the numbers close in the exam?
Mhm.
Like the numbers that you.
Wrong answers will be there too. All right, so I'm not testing chart 57-2. This is the when will a person be referred to a burn center? Okay, so because that's not our decision anyway. But I just want you to see, if you look at the criteria, does it really have to be a major burn? No, because look at it here. So let's say here, any children are automatically transferred. See, does it say major 3rd-degree burn? No, children have to be transferred. What about electrical burns? So all electrical burns or lightning injuries will be transferred. Here, doesn't specify how the depth, right? It just said anyone with facial, hands, feet, genitalia, or joint burns must be transferred. Does that make sense? Okay. So it's not based on the thickness, okay? There's certain criteria that require transfer. So here, also inhalation injuries, they have to be transferred to a specialty burn center. So chemical burns as well. Okay, so only the rule of 9, so you can disregard the Lund-Browder and the Palmar method. Palmar is literally using your palm to measure the burn injury. But we'll disregard that. As described already when I introduced the topic, the burns are exceptionally traumatic injuries. So this is what's going to happen to the body tissues. It's not just going to be a local injury. Remember what happened in severe sepsis, going into septic shock? You remember SIRS, systemic inflammatory response syndrome? Okay, this is also triggered in burn injuries. So therefore, even if, let's say, Hannah got burned only in her legs, let's say 36% or more, for instance, let's say both legs, that's what? That's 18. That's 36, right? Yeah, so both entire legs will be 36% or more. That will already trigger systemic inflammatory response syndrome. So she will have the same reaction, but the same systemic reaction that a septic patient will have, okay, in response to the burn injury. And this gets worse. So within 24 to up to 48 hours, the changes in her vascular system will persist. Okay, and then we'll describe that shortly. So here we've got electrical burns. The problem with electrical burns is, who has ever experienced electrocution here? No, like stupid stuff at home, you're washing something. You've experienced it, right? Okay, so you've been shocked at some point. So obviously you survived, you're here. So so lucky for you, okay, you didn't die. When someone gets electrocuted, seriously electrocuted, the burn injury is actually very small, localized, but the extent of the injury is internal. So as the electrical current travels through the body, because we are made of water, correct? And we are conductors, very good conductors of electricity, therefore. So it can cause major injury to the internal organs, especially the heart. So that's why all electrical injury burns must be transferred to a specialty burn center so they can take care of you more. Okay, because you have other issues besides the skin injury. So most electrical burns will have only two injuries. So there's the contact, which is the entry, and there's some sort of second exit burn. Okay, so there's an entry and an exit, because the electrical current has to exit your body somehow, right? And it usually doesn't exit on the same spot. So it will exit somewhere else in your body. So let's say you touch this, the exit might be the other hand, right? So we had that before. I was a nurse for a 5-star beach resort, and one of our electricians had like a stigmata. So when he was brought to the clinic, he had stigmata here. So they had two burns on each palm. One was the entry, and then it exited here on the other palm. We also have radiation burns. Now, radiation can come in different forms. So we have radiation from, let's say, cancer treatment. That's radiation, right? Could also be radiation from a power plant or from a nuclear weapons facility. That's also radiation. You still remember? No. Yeah, sunburn can also be radiation, but that's very minor though. That's a minor form of radiation burn. You still remember hyperthyroidism treatment with radioactive iodine? Okay, so that can also be potential, although we'll discuss radiation more under cancer later in the semester in November. So here's the details on electrical burns. As I described, the skin injury will only be superficial. The injuries, the major injuries are to the internal organs, including the heart. All right, let's go to the vascular changes now. So this is your heart's response to the burn injury. So does it trigger sympathetic nervous system? Yes. Okay. So the injury, the burn injury will trigger sympathetic response, and therefore there will be vasoconstriction and then increased heart rate. However, the the injury is so serious that it triggers increased capillary membrane permeability. Our capillaries are usually only semi-permeable, correct? Meaning they allow certain size molecules to pass through. If the molecules are too big, then they cannot pass through the capillaries. Examples are your albumin in the plasma. So albumin molecules are so huge. Sugar molecules are also huge. They cannot pass through capillaries. The only way they can enter the cell is, of course, through insulin, correct? So therefore, huge molecules cannot pass through the capillary membrane. However, in response to injuries like this one, so similar again to sepsis, the capillaries become very leaky. So they allow huge molecules now to go. And then, of course, what will happen according to osmosis? So if these molecules, large ones, pass through the capillaries, what will water do? Because now you've changed the osmolarity, correct? So if you move the particles, especially large molecules in the extracellular compartment or interstitial, what will happen to water in the capillaries? It will decrease. It will follow the molecules. It will follow via osmosis. Okay, so osmosis says water will move from an area of what area of low concentration to an area of high concentration. So this is what I mean by when the molecules now exit the capillaries, meaning they leave the plasma, they leave the bloodstream, they now go into the interstitial space, water follows them. So what will the burn injury patient look like? Dry or edematous? They'll be very bloated and edematous. However, where did that water come from? From the cells or from the bloodstream? This is increased capillary permeability. So where did this water come from? The bloodstream. So what happens to the patient's blood volume? So therefore, what's the problem in burns? Is it fluid overload or fluid deficit? It's actually deficit. But when you look at them though, they are so bloated, they are so edematous, you would think that they're in fluid overload, but they're not. They are very dehydrated. They are very volume depleted because should that water be in the interstitial space? That's supposed to be inside the bloodstream. But what happened? Why did that water go into the interstitial spaces? Osmotic pressure because of the capillary leak. So here, in response to the severity of the injury, the body goes into this self-destructive response mode. The capillaries become very leaky, leaking large molecules, especially albumin, and then pushing water out in the process. Okay, so the patient will become more edematous from the first 24 up to the next 48 hours. Understand? So they will look okay right now, but we expect them to become bloated over the next 24 to 48 hours. Including the non-burned areas. So initially, it may just affect the burned areas, but then 24 to 48 hours later, it will be systemic now. Sorry? We'll get to the interventions next. Okay. Blood typically no, because did they really lose blood or fluid? They actually lost fluid, right? So the blood did not leak out here unless they develop DIC, because these patients are going to go into septic shock eventually, and then they'll develop DIC as well. So yeah, when they have DIC, then yes, they will require blood transfusions now, because then they're actually bleeding already. So here's the problem. So I mentioned they're in fluid deficit, right? So they're now going to develop severe hypovolemia. So we call this burn shock. But if you review shock, what type of shock really is this? Because we only talked about 4. We never talked about burn shock in the shock chapter. So which one is this? Is this cardiogenic, obstructive, hypovolemic, or distributive? This is hypovolemic shock. But because it's caused by burns, what do we call it? Burn shock. Okay, so here, burn shock is initially a type of hypovolemic shock, secondary to. So how did this happen again? What caused the burn shock? The capillary leak syndrome. So the water shifted. Okay, the water left the vascular compartment into the interstitial space. Because why again? Okay, because this capillary leak here, the increased capillary membrane permeability, allowed the large molecules to leave. So now wherever those large molecules are, water will follow those according to osmosis. So here's your answer also, Kurt. So unlike traumatic injuries, wherein there's blood loss, this one, what's the only loss? Fluid only. The patient does not lose blood technically. Okay, so there's the shifting of the plasma from the vascular compartment into the interstitial space because of the capillary leak. Hmm? No. Okay, we'll discuss the management next. So here are the body systems, effect of burns on body systems. So like I said, it initially will be local. However, because of the severe injury, it will become systemic. So it will affect all body systems now. So starting from the vascular system to now cardiovascular, pulmonary, we will discuss ARDS. Burn injury patients typically develop acute respiratory distress syndrome. Because imagine the same, you can imagine what's happening to the capillaries, right? So the burn injury, that's why it will swell. Patient will get bloated, but imagine in the lungs, how many capillaries are in the lung tissue? It's basically filled with capillaries, right? Because we have 100 million alveoli, correct? 100 million air sacs. Each one of those 100 million air sacs is wrapped with a capillary network. So if each of those capillaries become leaky, just like this here, what will happen to the lungs? Pulmonary edema. There will be fluid in the alveoli. The lungs will fill with water. So now how can gas exchange occur? Okay, so you still think burns is a minor injury? No. So this patient will go into shock, into hypovolemic shock. They can also get infected, add septic shock there at the same time, and then they will also have ARDS and DIC at the same time. What do you think? Okay, so we don't know how long, just like in COVID or in any sepsis scenario, we don't know how long this intravascular fluid leak will last. We have no idea. There's nothing we can do to stop it. That's why You remember how we lost so many people during COVID, right? So this is what was happening. So when you go into sepsis, you go into systemic inflammatory response syndrome. So the capillaries become leaky, and then that's what happens to the patient's lungs. They develop ARDS. It's so wet, it's impossible to ventilate the patient. Okay, so that's how we lost a lot of people. So it's either ARDS that killed them, or they develop DIC, okay, as a consequence or sequelae of the sepsis. So this can last anywhere between 24 to 36 hours, but we don't know exactly when. So all we can do is keep them alive until this stops. Okay, we cannot, there's no medicine that will suppress the body's response. This capillary leak syndrome, this is this self-destructive response to a major insult or injury. There's nothing we can stop it. It's just a very, I don't know what else to call it. Self-destructive, really. Why does our body, react this way to a serious injury? So we've tried steroids, it doesn't work. Okay, it doesn't suppress this self-destructive response. And then hopefully the patient's body stops with the capillary leak syndrome, and then fluid shifts back. So this will be equal to, still remember the stages in AKI when there was oliguric and then diuretic? Okay, so if the patient survives, we kept them alive during the first 24 to 36 hours of the capillary leak after the burn injury. So once they reach the diuretic phase, then that's a good sign. Okay, so when they start to diurese, because will this patient also develop AKI? What type? Pre, intra, or post-renal? This is pre-renal because this is hypovolemia, right? This is shock. The patient is in hypovolemic shock. So there's AKI also here. We won't repeat it. Obviously, AKI is not discussed in this chapter. So this is only for burns. But understand, besides the burn, besides the shock, the patient is in AKI. Now let's go to the electrolytes here. So as the fluid is shifting, right? First 24 to 36 hours. So what will happen to the patient's serum or plasma potassium? What does this say here? And think also of the burned cells, because there were several cells, millions of cells destroyed by the burn injury. So those will spill it will spill potassium into the bloodstream. So initially it will increase. So the patient will have initial hyperkalemia. But of course, this patient, as the patient's given fluids, and plus when they reach this diuretic phase here, let's say they survive, what will happen to potassium? It will drop. So initially it will be high, and then it will drop. So is that also difficult to handle? Yes, because now you're treating the hyperkalemia, right? And then all of a sudden, the patient enters the diuretic phase, and then it drops. Now you're screwed, right? So it's really, these are critical patients, right? So that's why they need to be in a specialty burn center who know what they're doing. So they handle these patients day in and day out. Okay, so there are phases in the management of burn injury. We will, there's really a pre-hospital, or we can also call that a initial phase, because let's say you got burned, Rihanna and Hannah. Are you likely to receive something at your party or at the nursing home? Because it's going to be a while, right, before EMTs come. We've got what, about 5 minutes? Okay, so what are we going to do? What will they likely receive during the first 5 minutes, which is our pre-hospital phase? Are we just gonna leave them? Okay, just like this. Okay, wait, EMTs are coming. Okay, chill out, stop yelling. Are we gonna do that? Okay, they're bound to receive something, right? Let's say in her case, what will you do to Hannah? She got oil, hot oil in her legs. She's now on the ground, wailing in pain. So someone was gonna put, some wet towels, right? Okay. One thing you don't put is what? Are we gonna put her ice cold water?
No.
That's not advisable. That would be good to put the fire out, to put the flame out, but what will that do to her blood vessels? It will, ice cold water constrict, further compromising blood flow. Okay, because we already have capillary leak. Okay, so blood vessels were already burned, so we don't want to put ice, which will cause more vasoconstriction. That will actually compromise circulation. So can we put something cold though? Yes, so that will help her feel comfortable and then put out the fire and then stop the burning, right? Because you cool down the oil. Same thing for Brianna. So she got the acid. So what will Kurt most likely do? So Kurt will probably yell, "Ah, my God," and then take her out of the acid, right? And put her on bed and then start to wash her, correct? To remove the to try to remove the chemical of her skin. Right. Okay, let's talk about the reaction of the skin. You remember compartment syndrome? What was the nature of compartment syndrome? Let's say you had a fracture of your arm, leg. What happened? How does compartment syndrome develop? What was too tight? The cast or the dressing, correct? Here, what will act like a tourniquet? Just like a cast or a dressing. So when you burn an entire skin like this one, so this one's already cut. This incision that the doctor made here, right there, is called a escharotomy. So the eschar here, you've had crispy pork belly. Have you heard of that dish? Yeah, very crunchy. So what happens to skin when you burn it circumferentially, meaning you burn an entire arm or an entire leg? What will happen to that skin if it's burned to a crisp? It will act like a cast or a tourniquet. So will this patient develop compartment syndrome? Yes. So the patient will lose that arm or that leg if we do not do something. So the doctor will perform an escharotomy. So he'll cut through the eschar, through the crunchy burnt skin, and then release the pressure, relieving the symptoms. So let's review our compartment syndrome signs and symptoms. So what are those 6 P's? Pallor, pain. When we say pain, it should be unrelieved pain. Okay, unrelieved pain. Next, paresthesia, poikilothermia, pressure, paralysis, right? Don't forget pulselessness. Okay. Now, poikilothermia is not really counted. It's because it's really unrelieved pain, pallor, pulselessness, paresthesia, pressure, and paralysis. Okay, so that's 6. Because poikilothermia is kind of late, so we don't count that because we prefer early manifestations. If it's late, I mean the limb is gone. Okay, the patient will lose that leg already. Does it have to be all 6 P's? Can you say, oh, we only have 3 P's? 1 P is enough to suspect compartment syndrome. So what do we do once we suspect compartment syndrome in a burn injury patient? Can you make this cut yourself? Okay, call rapid response and they have to come and perform the procedure. Immediately. Okay, so we call that procedure escharotomy. What did we do with the traditional compartment syndrome? What was that procedure? Same thing, they cut. Kurt? No, yeah, we remove the cast, but we have to cut the... So if this is escharotomy, that cut is called fasciotomy, remember? We cut through all the fascia. You know, fascia, the thin membrane covering the muscle. When you buy steak, there's a thin, yeah, so we cut through there, we expose the muscle. Okay, we do a deep cut up to the fascia and then expose the muscle. That relieves pain, that restores blood flow and nerve flow to the tissues. So if the patient makes it, we kept them alive for the first 24 to 36 hours, and then they hopefully reach the diuretic phase, and then they'll hopefully survive. So we said hyperkalemia first, right? Followed by hypokalemia. For as far as sodium, it's really it's not very predictable. So sodium will remain low in both phases. The patients will lose a lot of sodium because we're losing a lot of fluid. So here's another, this one's fasciotomy already. See, that's muscle. Okay. So this is a deeper cut. So that's fasciotomy already. So the other one we saw was escharotomy here. So that's escharotomy. And this one is fasciotomy.
So, they take the first, let's say that's this white.
That's the fascia. This white thing here,
Yeah.
that's fascia.
So they remove it surgically?
That's what you cut to expose the muscle. You relieve the pressure because the edema is so large here. So the patient will lose all this, the entire arm, if we do not restore blood flow. Because you know the pressure is so tight, it's like a tourniquet, so no blood flow is going through. So the only way to restore blood flow is to cut through the yeah, in the case of the fasciotomy, we cut through here, fasciotomy, we cut through all the way to the fascia, and this one we cut throughout the eschar. So this is crunchy, okay? This is all crunchy skin. So you can see here, no? Not, although not as crunchy as I would want it, but you know, it's leathery enough to apply pressure. I'll probably put this for another 45 minutes at 375 degrees before this thing gets crunchy. Then you get some vinegar, a little bit of soy sauce, garlic, onions, pinch of salt, lime. We're good to go. Open 12-pack of Modelo. All right, we have a party. And labs, of course, because is this patient in fluid deficit or overload? Deficit. So what will be the H&H? These are all part of your test, okay? Because you're expected to know this already. We finished 241 fluid electrolytes. We finished shock, dehydration. We finished heart failure. So what will be the labs? Will it show high or low H&H? High. Why? Okay, fluid loss. What will be the BUN creatinine?
No.
High. Again, volume depletion. So I already mentioned pulmonary alterations, the ARDS, but we will discuss ARDS in a whole chapter later in the semester. Because of the nature, so let's say we have a patient with inhalation injury. When do we intubate? Early or later? When do we intubate? Knowing what you know now about what will happen after burn injury. Okay. So let's look at a few pictures. These are old though. Let's look for something cute. These are already all alive. Let's look for someone who's still intubated. Here. So this patient here, so this is a burn patient. This is what they're gonna look like. Okay, and it'll get worse. This edema that you see will get worse over the next 24 to 36 hours. So do we intubate early or late? Early, because now you may not be able to pass that tube into the airway, because if this is swollen over here, how much more inside? The throat and the neck will also be swollen, all right? So initially you may hear lung sounds, so you'll hear stridor, you'll hear wheezing, but later the sounds will disappear. What does that mean? The airway is closed. Because remember, the only way you hear lung sounds is air is going in. Now you hear nothing. What does that mean? No air is going anymore. So airway is already closed. So now the only way is to tracheostomy. At that point, no more. Trach now. Okay? You have to go invasive now. All right, so we need to know the signs of, let's say, how do you know you need to intubate? So we need to know signs of inhalation injuries, correct? So how will you know the patient sustained inhalation injuries? Okay, it's respiratory distress. What else? What will you see in the mouth? So here, what are the signs? Singed facial hair. So let's say this patient is sick. Okay, and then only this part here has hair. This part, no more hair. So what happened? It got burned. Okay. What about no eyelashes, no eyebrows? Okay, burned off. Or the patient has any neck burns. Remember I said fire burns up. So always, okay, always suspect inhalation injury. If there's any burn, the shirt was burned off, always consider they have sustained inhalation injuries. And then when you open the mouth, what will the mucous membrane look like? Okay, there's black, there's soot, or let's say when they cough, the sputum is colored black. There's soot in the secretions. Okay, so indicating this patient has sustained inhalation injury. So you call the doctor to perform intubation right away. So call rapid response. We need to intubate right away. See all these signs here. So black, soot. If we can do bronchoscopy once the patient's stable, we need to clean out the lungs. Okay, we need to clean out the debris. Maybe there's charcoal in there or whatever's in the airway. All right. Let's talk about carbon monoxide poisoning. So let's say what's carbon monoxide again? It is a clear, colorless, odorless gas. All right, so can you tell someone's already in CO poisoning? No, because the only symptom is the patient will feel drowsy and sleepy. What will you do if you're drowsy and sleepy? You go to sleep. Will you wake up? No more. Is it a painless death though? Yes, peaceful, painless death. Remember putting a banana in the exhaust pipe in your car and closing the garage door? You know how to do it? No, that way you don't hassle your families, okay? There's no blood to clean up. It's a clean way to go. All right? Although you may crap yourself though. So they still have to wear a diaper. All right? That way it's easier to clean you up. So the problem with carboxyhemoglobin, this is because if you give the hemoglobin molecule a choice between CO and O2 or CO2, what do you think the hemoglobin will grab? It will grab CO. Because look at the chemical composition. It's only one carbon and one oxygen. Oxygen, which one's lighter, oxygen or carbon? Carbon. So which one will it rather take? Carbon monoxide. Okay. So if all three gases are available in the bloodstream, carbon dioxide, carbon monoxide, and oxygen, the hemoglobin will rather grab carbon monoxide. It has a higher affinity for carbon monoxide. So the only way we can tell is the only manifestation here is the patient mucous membrane will turn cherry red. What is cherry red? Dark red, okay? Like cherries, okay? Right? Really dark red. And of course, the patient will have some here. So the patient will have shortness of breath, headache, vertigo, confusion, and the mucous membrane again will be colored cherry red. The only treatment for carbon monoxide is what? Oxygen. Yeah, just flush out the CO, flood them with oxygen. Okay. Kidneys, again, you already finished AKI, so this patient undergoes AKI. Are these patients at risk for infection? Yes, no skin, no protection, so highly susceptible to any infection. Ironically though, burn centers actually, yeah, they have private rooms for critical patients, but their stable patients are actually in a ward. You know what a ward is? No, like you've seen in Bellevue wherein they have 6 or 8 beds in a room. Yeah, like that. They have wards. Yeah, they have 6, 8 beds in a ward. That's the setup at burn centers. Critical care patients, of course, the first 24, 48 hours, those are intubated. They're in private rooms. But when they're just being treated for the wounds, because that would be in the acute phase, they're actually in a ward. Because again, no skin available, so will there be a thermoregulation problem with these patients? Yes. GI, sympathetic response, will there be any blood flow to the GI? Or if there's none to the kidneys, that means, will there be any to the GI tract? Okay, so do we have some ulcers here? Yeah, do we have some constipation? Okay. Nausea, vomiting? Okay, so there will be decrease or absence of peristalsis. And they'll develop ulcers. And we finish peptic ulcers already, there'll be GI bleeds. Any questions? All right, let's go now to the management. All right, so on the scene, like I said, somebody's bound to do something to Brianna and to Anna. So we have a, here's a summary of the phases. So I mentioned the pre-hospital is not mentioned in the chart or the table. So on the scene here, somebody's bound to, put out the fire, whatever. As far as IV insertion, it depends. If the patient has available veins, let's say the burn is in Hannah, for instance, the lower leg, so we can use her arm still, right, to start an IV. But with vasoconstriction, will it be easy to start the peripheral line? Probably not. Her veins will be all constricted. In the case of Brianna, her arms will start to be swelling already, right? Because the back half was burned. So it may be difficult to start an IV. So it depends if the patient is available for IV insertion. But anyway, so we always start with airway, correct? So we provide airway support, oxygenation if available. So that's the pre-hospital care. So somebody's bound to render first aid at the scene. And now we have EMTs coming. So that's now the start of the emergent or resuscitative phase. I don't know which one the NCLEX will use, but when you see emergent or resuscitative phase, this is the, what do we mean by resuscitation? We're referring to fluid resuscitation, okay? So the patient will receive tons of fluids here. When emergent or resuscitative phase usually lasts between 24 to 36 hours. After that, if they survive, they enter the acute phase. So acute phase begins around 36 hours onward. This is now when the patient enters the diuretic phase. of AKI. And so our focus here, obviously in the resuscitative, is airway support and then IV fluids. And we begin pain management and wound care. However, in the acute, is the patient still receiving lots of fluids here? No more, because they're in the diuretic phase, right? So now we're focusing on wound care and pain management in the acute phase. This will be long. We will not bother with the rehab phase. This is even longest. The patients in the rehab phase are stable anyway. So these patients will just do rehab the skin, rehab their, the joints, or they will undergo functional or cosmetic surgeries to fix the appearance. Okay, so that will be, for some, they will be a lifetime. Okay, so the rehab phase really could be indefinite. It could be as long as the patient's the rest of their life. So here's your first aid, 57-4. Please use common sense. So let's say we know it's ABC, correct? So airway is our priority. We want to apply oxygen. Will you apply oxygen if the patient's on fire?
No.
Are you gonna do this like that? Oh, okay, of course. So use common sense. So put the fire out first and then apply the oxygen. So whichever applies, right? Do we use ice again? No. Here, you can cool it, but no ice, okay? Do not wrap the person in ice. Never use cold soaps for longer than 20 minutes. Okay? So short periods, 10 minutes, just to cool it down. Okay, we can use cool, but not ice cold. Remove restrictive objects. This could be jewelry, any clothes that have that are restrictive. Let's say, I know Hannah likes spandex, so we have to remove her spandex to promote circulation. And cover the wound. Remember, there's no skin, so protect the wound. Apply clean or sterile dressings if you have them. The dressings, though, must be non-adherent. You know what is a non-adherent dressing? Have you seen the gauze we have in the lab? Not the woven one, the non-woven gauze. Yeah, it doesn't stick. Yeah, so use that kind, because you don't want to put something that sticks here, because now you'll have a problem removing it. If it's chemical burns, I know this section says irrigated. However, if you're not familiar with a chemical, probably not the safest thing to do, because you don't know, unless you know the chemical and you're trained. Let's say you work in a factory, so OSHA requires that everybody's trained, right? So you're using this chemical, you should know first aid. You know what to do, what to neutralize it if you have exposure to that chemical. But if you're not sure, some chemicals react with water. So if you're not sure, just let the expert handle it. Okay, so do what you can. So let's say there's something stuck which is not adhered, so you can remove that. Okay, so if it's a dry chemical, that's good. Do not wet it, just brush it off. Okay, make sure you have PPE, brush off the dry chemical. But if it's wet, unless again you're familiar with that chemical, yeah, go ahead and render irrigation. But if not, then don't bother. Okay, we mentioned this earlier. I showed you a picture of what a patient looks like after burn injury. So we expect the swelling to get worse over the next 24 to 36 hours. So when do we intubate again?
Right away.
Early, okay. And keep them NPO, so we don't know if they're able to swallow or not, or they may vomit and then you cause aspiration. Okay, let's go now to the fluids. All right, this is our formula. This is called the Parkland formula. Parkland as in, remember Parkland, Florida? Shooting? Okay, Parkland. Parkland formula is disregard the 2. Nobody uses the 2. Everybody uses the 4. All right? So it's 4 mLs per kilogram per TBSA. Again, 4 ml per kilogram per TBSA. So how much do you weigh, if you don't mind? 100. Okay, 100 pounds. So how many kilograms is that? 100 pounds divided by 2.2 is, okay, so she's 45. Let's just say 45. A nice number. 45 kilograms times 4, right? Times 4 ml times, what was her TBSA? 50.5 times 50.5. How much is she getting? 9,090 mLs for the first 24 hours. Again, how did we get this? What formula did we use? 4 ml times kilogram times TBSA. So we calculated her burn TBSA was 50.5. She weighs 100 kilograms, which is, we rounded it to, let's say, 45 kilograms. But on the exam, no rounding, okay? So keep it at the decimal. So that you, because my answer choices will be up to the 10th decimal place. Are we clear? So just for this practice, we'll keep her at 45 even. So she's gonna receive what? 9,090 mLs for over what? Over how long? 24 hours. Okay, everybody look at Brianna. Can we put 9,090 ml in Brianna? That's 9 liters of lactated ringers. Where are you gonna put it? But the formula says that's how much you give. In the first 24 hours, she's gonna receive 9,090 ml. So here, first of all, how do we give it? Is it gonna be given one time? Are we gonna dump 9 liters? Okay, so here's the administration. The starting point is the time of the burn injury, not the time of arrival to the facility. Again, the 24 hours is counted when? Time of the burn injury. Because when did she start losing fluid? When she arrived in the ER or when she got burned? Once she got burned, she started losing fluids because the capillary membrane permeability started increasing at the time of injury. So she started leaking fluids at the time of injury. So there's 2 types of fluid loss here. On the area where did she got burned, is there any skin there? No. Is any membrane holding the fluids in her body? No. So let's say her on the back of her arm there, for her entire back, from her head down to her heel, there's no skin, so therefore water is evaporating from her backside. Plus, at the same time, water is also shifting into her interstitial space. So there's 2 types of fluid loss. There's actual and there is relative, correct? So there's absolute water loss, no, actual water's loss, but she's also losing water relatively, meaning it's not in the bloodstream. She technically lost it, but did it leave her body? No. It's somewhere in between the blood vessels and between her cells. So they're basically useless, correct? However, when you weigh her, that water that's in between the cells and the bloodstream, was that included in her weight? Yes, so therefore, is her weight accurate? Is there any way to get an accurate dry weight on her when she's already edematous? No. So therefore, what can you say about the 9,090? Is that accurate? No. That is an estimate. Do we understand each other? Okay, that is only an estimate, okay? But better than nothing. So we will stick with whatever her weight is. It would have been better if, let's say, we managed to weigh her before Kurt put her on the acid, okay? But let's say we did not get a weight for her today. We based her weight either on her actual weight or whatever weight was recorded last, okay? So most of the time we use the weight now, whatever weight we got available. So therefore, is this formula accurate? Why? The weight is not accurate. Okay, so the weight we have is the weight of someone who is already third spacing, who's already edematous. But we'll still give that. So how are we going to give the 9,090? Okay, so half of that total will be given over how long? First 8 hours. When do we count the 8 hours again? Okay, so since it's counted from the time of the burn injury, does Brianna have 8 hours when she reaches the hospital? She does not have 8 hours. Why? Yeah, we had, so let's say Kurt burned her, right? And then Kurt panicked, discovered, and then called 911. So it took 911, what, how much? Let's say her nursing home, her room was on the 5th floor. So we'll travel through, let's say it's raining today. So it'll be a while before EMTs come. Then they'll take the stretcher, take the elevator up 5th floor, take the stretcher there, grab her, try to start an IV, provide oxygen to her, okay, and then handle her, and then take her on the stretcher, down the elevator, back to the ambulance, and then through traffic and rain again, and then finally she'll reach the ER. So how much time could we potentially lose? Easy, right? Okay, so therefore, we need to know what time was the injury. When did she get burned? So the doctors, when they start the fluids, when you calculate half, which is how much? 9,090 divided by 2, 4,545 will be given. So let's say she lost 1 hour. You divide this by 8. You divide it by 7. So on the scenario on the test, I'll give you what time she got burned and what time she got to the hospital. All right. So now we have 9,090 divided by 2. So we divide this by however time you have left on the first 8 hours. Okay, so it depends on how much time she lost. So let's say she lost only 1 hour. Divide this by 7. So she's going to get how many mLs per hour? 649 mLs per hour. What type of IV access will she require if it's 649? Can you put this through a peripheral, a measly peripheral line? Can't handle that. She has to get a central line. So doctors will insert either a jugular, non-tunneled, or a subclavian, whatever we can get, and give her 649. What do we do with the other half? The other 4,545 over 16 hours. So be careful on the test question. What is the question asking? Is it asking for the first 8-hour rate or the next 16-hour rate? Are we clear? So everything will be given to you though. I'll give you her weight. That's about it. You need her weight, right? Because you know the formula is 4 ml. How do you get the TBSA? You have to calculate that as well. So I'll just describe which body parts were burned. So that's like a double calculation there. So you're calculating the TBSA and also calculating the fluid resuscitation. All right. And believe me, wrong answers are on the test options as well. I'll spend like 8 hours making that question. Just for you. Just for you. Okay, again, let's continue. What did I say? Is this formula foolproof? Is it accurate?
No.
No, these are only guidelines. These are estimates, okay? So how do we know that she's really getting enough fluids? If the 649 mLs per hour was really accurate, how do we know? Or if it's too much or if it's not enough, how? How will you know? Be specific. Hourly urine output. If she makes, what's the minimum?
30 ml.
If she makes 30 ml per hour, or in this case, since she's a critical patient, we can also use 0.1 to 1 mLs per kilogram per hour of urine, then she's getting enough. What if she's not she's not making that much urine? She's only at 649 mLs per hour. She's only making 20 mLs per hour on the Foley. What do you do? She has a Foley. That's how we knew her fluid.
Diuretics.
Give the diuretic. You're gonna kill this patient's in shock. You're gonna give them a diuretic. Okay, notify the doctor. He'll probably increase or decrease the fluid. Increase or decrease? She's only making 20. Remember, this patient's in AKI, so
Hold on, she's retaining fluids, right?
Yes.
She's retaining fluids.
how did we get to retaining fluids here? I thought we got this out of the way already.
Hold on.
When did we mention that the burn patient has retaining fluids? What's the hypovolemic shock patient retaining fluids? Is that why they have no urine output? Am I talking to a wall here?
No, we just get an emergency message. We're distracted. Yeah.
I can't do that. We spent an hour talking about this already. I can't repeat it. Can't repeat a whole hour. No, I want to address this first because this is serious. This will destroy the whole thing. Is the patient in burn patient in fluid deficit or overload? So how do you throw the diuretics here? This patient has low blood pressure. This patient is in shock. You give this patient diuretics, what will happen? You'll kill this patient.
So the patient is not voiding. So if you taking it fluid and not voiding, what are you doing? What's the fluid doing?
I know the person is in hypovolemic shock, so it's taking time for the person to get the body.
So it has to back to
The body has to get normal, then. For the
retain fluids.
I mean, she's not making urine because is there enough blood getting to the kidneys? No, remember pre-renal AKI. Pre-renal AKI. Okay, are we clear? Are you okay? All right. So again, we're infusing 649 ml per hour. She's only making 20 mLs of urine per hour. What do we do? And you expect to do what? Increase. We already have a Foley. That's how. Okay. What's our basis therefore? Is it the weight? Is the weight more reliable here to determine her fluid status? What is the more accurate here? The hourly urine output. Okay. So this is the one exception. Okay. So everything else will you learn from heart failure, kidney failure. What was the most accurate weight? Measure of someone's fluid status? It was the weight, right? This is the only exception. We cannot rely on her weight here. A burn patient's weight is during the first 24 to 36 hours is not reliable. Why? This is a weight of a third spacing patient. The weight of a patient who has already the capillary membrane permeability. She's already edematous. It's not an accurate weight. All right. So the basis again, either 30 ml per hour or 0.5 to 1 mLs per kilogram per hour of urine output. Are we clear? Very good, children. You can also use the basis. Can we use the mean arterial pressure? Is this patient's in shock? Yes. What do we want the minimum to be, MAP to be? 65 or better. Okay, so you can either use the, or both, MAP of 65 or better, or a urine output of 0.5 to 1 mLs per kilogram per hour. The other interventions here are if she has other injuries. So let's say, like I said earlier, if someone, a burn patient, thrashed around and sustained head or neck or spine injuries or any other or fractures, for instance. So make sure her temperature is monitored. Oh, because deep burn injuries are serious wounds, she would be given tetanus booster. All right. Unless we know that she recently received one, then it's not, that should suffice. Alright. How's the family of Brianna here, or Hannah? How are they doing? Okay, so this would be serious, right? So make sure you take care of that that family as well. So let's go now to the acute phase. So any question about the resuscitation phase? The formula? All right, and the evaluation of whether or not we're giving enough? Very good, children. Acute phase again, so this patient survived the most life-threatening phase. So she survived the hypovolemic shock, she's alive, she's now diuresing. Now, she's not out of the woods yet because she still has burn wounds, correct? Can she still get infection and sepsis? Okay, so equally important during the this is now acute phase, which the focus is now on wound care and pain management. So we have to make sure we perform wound care properly so she doesn't get any infections. Please take note that when you do wound care, we use, so let's say she has wounds on her head, correct? Her back, each arm, and then each back of the leg also. Do we use the same equipment for each burned area?
No.
Why not? Okay, we do not use, even though this is the same patient, we use different sets of dressings, okay? Because we don't know if they're all clean. One wound area may be infected, the other may not be. So to prevent cross-contamination, we use a dedicated wound care equipment for each body part, for each wound. Is that clear? Okay. And especially if you're in a ward now, so make sure you don't use the same cart to do everybody's dressing in that ward. Okay, so one cart for each patient. Are we clear? That way we use dedicated equipment for each wound and of course each patient. As far as antibiotics, because remember, this patient has extensive wounds. Do we do systemic or local antibiotics? Okay, let's read here. The problem with using, when we say systemic, what do we mean by systemic antibiotic? What preparation is that? Is that oral, IV? IV only? What about oral is not systemic? Okay, so oral or systemic or IV are systemic, right? So what's likely to happen if we do it prophylactically, if we keep giving her antibiotics? Because remember, this wound will be a while before this heals. So if we put her on systemic antibiotics for that entire duration, what will she develop? We are creating multi-drug resistant organisms. You're right. So is it a good idea to put her on systemic antibiotics? No, we only use local in the form of topical. So what do you use over the counter to treat burns? What do you call that ointment, that white cool ointment? For burns. It's called Silvadene. Okay, Silvadene is silver sulfadiazine. So it has silver, which is an bacteriostatic. Bacteriostatic means they'll prevent bacterial growth. And sulfa, which is an antibiotic. So we'll use that topically. Are we clear? Okay, so that's what we'll use. We'll put that on the dressing and then use that dressing to wrap her wounds. Okay, so topical. Are we clear? So topical. We only use systemic antibiotics if she looks infected, if there's evidence of infection. Are we clear? Otherwise, will local suffice? We better use local because we don't want to create multi-drug resistant organisms. Is that understood? As far as positioning, I won't test it, but if you ever get it on the NCLEX, look at what happens to skin when you burn it. Look at what happens to the skin when it heals after a burn. What happened to it? You stretched or pulled. It pulled. Yeah, so that's what we call a contracture, right?
Yeah.
So when a skin heals, it will contract, it will pull, right? So therefore, what will be a better way to prevent this? Because it will contract, so that you don't have limitation of movement. Let's look at a before and after. This one. Look at this. So it pulls, right? So what happened to this patient's range of motion?
Decrease the proportion.
Okay, so how do we prevent that? What position would be best so that the skin doesn't contract like this? Do we stretch it, or do we extend it, or do we flex it? Well, the answer will depend on the body part. So let's say I got burned here. I got burned here, anterior neck. What position will you put me? Flexion or extension?
Extension.
Very good. So I will put you on an extension so that the skin is
Stretch.
pulled, so that when it contracts, I have range of motion. Make clear?
Yeah.
So the answer would be, well, depends really on the body part. Because let's say I put the wound now on the back of my neck. Do I extend or flex?
Flex.
If it's the bend of my elbow, antecubital, what position? Extension or flexion?
Extension.
If it's my elbow, flexion or extension?
Flex.
Okay, you got it. Alright. So that's how you answer, okay? So you pick the position that will stretch the affected area. Say again? What will happen to the scar? No, not with these. You need proper positioning. Now, what if it's the entire body, head to toe? That's burned.
Okay.
You have a problem with, you can't flex, you can't extend, right? So what we'll do is we'll put a compression garment on the patient. We'll put tight garments. That way it's going to apply pressure on the affected area. Just like you, they'll lay on anything. Yeah, but they'll wear compression garments. Here, let me show you. Like this, see? Entire, say the head, it's difficult, right? Because you can't, because the whole thing is burned, so you can't choose between flexion and extension. So we'll just wrap the whole thing with a compression garment until the skin heals, when the scar forms. Depends on the age, but several months. Several months. All right. As I said, I'll discuss ARDS. This is now the pulmonary complication of burns. That's a whole section here, chapter 19. Okay, so we'll do that later in the semester. I think we're done. Let me just make sure. I'm not testing the graphs because again, are we working in a specialty burn center? No. Plus, if ever you get a question on the NCLEX, the question will probably on graphs is whether or not they're infected. How do you know something's infected? What will it look like? Okay, there's odor, there is drainage, yeah, there is. Yeah, the color will be red, yeah, inflamed. Okay, so you know. Anything that's infected will look the same, right? What would be the best route here during the acute period? What would be the best route for the pain management? IM, sub-Q, PO, IV, topical. What would be the best?
What?
These patients are in pain.
That's okay.
IV. Okay. Why not IM?
But the skin.
Skin.
Okay, very good. Oh, nutrition. These patients are in a hypermetabolic state. What does that mean? So how much calories do these patients require? Up to 5,000 kilocalories a day. Like someone, you know, training for a boxing fight, that much. Because they're in a, I mean, their body is actively repairing tissue. So you need to support that. Because otherwise they'll be wasting, they'll have muscle wasting. So you need to support the hypermetabolism. So high protein, high calorie diet. May need to be through a NG tube initially. Preventing infection, yeah, of course. Pain management and rehab. So we discussed the positioning. And we finished sepsis already. Can they also go into heart failure?
Yes.
Yeah, because can we miss the period between yeah, the oliguric and the diuretic phase? Okay, so be careful, okay?
They also have heart attack due to the
Yeah, they can have blood clots too, yeah. Can have DVTs. Okay, that's it for burns.